Good day, everyone. This is Dr. Dempsey again On Call with Doc Dave. And thank you for tuning back in because I have a good episode today on something that pretty much everybody has been exposed to at one time or another in their life. It's episode number 10, and it's called Fractures. So what is the definition of a fracture? Definition of a fracture is a complete or partial break of the bone. And the person who has the history of the most fractures ever is somebody that most of us recall. Evel Knievel had 433 broken bones or fractures, and there's only 206 bones in the body. So he's broken everything twice. Crazy. The most common fracture, the most common bone to break is the clavicle, and it's usually the most painful, except for a femur fracture. So, let me explain to you the 8 different types of fractures. First one is called a green stick fracture, and that happens in pediatrics because the bones aren't completely formed yet and they're not brittle. And when you break a bone, if you're 2 or 3 years old, you generally don't fracture the bone all the way through. It kind of splinters like a green stick, and it keeps the alignment in place, and it's relatively easy to heal. The second one is your most common fracture. It's a transverse fracture. It's a fracture in a straight line across the bone. The third is a spiral fracture, which is pretty much what it says. It's a spiral break around the bone, and that usually has a good alignment as well. The fourth is an oblique fracture, which is a diagonal break along the bone. The fifth is a compression fracture. It's a crush fracture, and this is an orthopedic emergency in children because you have the growth line that you have to protect. The metaphysis, epiphysis, all the blood supply to a particular joint that is still growing in anybody under 14 years of age. So this is a very dangerous fracture and one that you have to be very aware of and usually get orthopedics involved immediately. The sixth one is a comminuted fracture, which is a multiple bone fracture, which is somewhat complicated to heal. It's a fracture in the bone where it breaks in like 3 or 4 places, and they can all be separated. And this usually requires open treatment by an orthopedic doctor and a surgical procedure where he realigns all of the fractured pieces and puts a plate in there with screws so that they stay aligned while they're healing. The seventh one is an avulsion fracture, and this one is where the ligament pulls away from the bone and removes a piece of bone from the normal anatomy of the bone. And this could have some complications and long-term healing issues as well. And the last one, which is also an orthopedic emergency and very dangerous, is an open compound fracture of the bone, where the bone actually breaks through the skin and is protruding and it is visible. And that requires urgent orthopedic OR into the operating room and open and clean out the wound so it minimizes any potential infection. And then they can realign the bone and plate it and screw it as well. So those are the 8 most common types of fractures. Now, how long does pain from a fracture last? Well, obviously it depends on where the fracture is and the degree of fracture, but usually it's 2 to 3 weeks of pain. And how do you initially you go into the emergency room, the doctor, takes a look at you, if it's, looks like it's a relatively common fracture, he gets an x-ray. And depending on what the x-ray shows, they generally just put a splint on it initially for the first 48 to 72 hours because there's always going to be some associated swelling with an acute fracture. And you don't want to have a tight cast on initially because that'll compromise the circulation. So they put a splint on for 2 to 3 days, then they have you come back, reevaluate it, and then put the cast on if it's a relatively simple fracture. But we'll go over that later in treatment. So, orthopedic emergencies, these are very important. I mentioned a couple just a few minutes ago, but everybody should know, what to be concerned about in a fracture and what not to be concerned about in a fracture. So, orthopedic emergencies. Number one, compression fractures in pediatric, which is I just mentioned above. This is a growth plate that gets compressed on itself, and it could affect the circulation to the bone, which will prevent the bone from growing in the future. So if you don't take care of this, you can have a shortened arm, you can have a shortened leg. You don't see this too much anymore because, the pediatric orthopedics and trauma is, very efficient in taking care of these and getting the circulation improved on an urgent basis. So, but it's something that you've had in the past. And if people ignore this, if their child falls and, hurts their arm, but they don't think much of it, and they delay getting it looked at for a few days or a week, then they finally take them into the emergency room and say, geez, my kid fell and his arm's still hurting him. Can you take a look at it? Then you look and you see it's a compression fracture that maybe has, compromised the growth plate. And now we got a real problem here. So those are the kinds of things that need to be looked at right away. Second one is compound fractures, open fractures, because obviously the bone is now exposed to the environment and it can easily get infected, and you can get an osteomyelitis, which is an infection of the bone. If there's some debris around it, if you fell on a bike and you got dirt and grass in the area or any other thing, or you're going to have that bone contaminated, it's very dangerous and that could be limb threatening. Number three is a fracture of the distal humerus with angulation in pediatrics. And this is, again, similar to a compression, but a little bit different of an animal on the fact that if the fracture is angulated to a certain amount of degrees, which we won't go into in detail, it's too complicated, and you don't get it taken care of immediately, that angulation can evolve the circulation and cause, a circulatory issue distal to the fracture where you could, compromise and possibly lose the limb if you don't take care of it initially. So that's a very significant fracture. Got to watch these pediatric fractures because of the growth and the circulation issues. Number four is a navicular fracture, or what they call a scaphoid fracture. This is usually mostly 90% in the wrist, can happen in the hip, but usually in the wrist, where the navicular bone, which is one of the 8 wrist bones, fractures. Now the problem with this is twofold. First of all, you don't see it initially because it's such a little hairline fracture. You may miss it on the initial x-ray, but you got to look at the history and you got to do a good clinical exam. And there's something called an anatomical snuff box where you stick your thumb in it, and if that hurts the person in the anatomical area where you're doing it, right over the navicular bone, then that's an indication that there's probably a subtle or fracture of that bone and it needs to be attended to immediately. And that brings us to the second complication with this fracture, is that the circulation is very poor in this area, and the distal part of the fracture and even the proximal part of the fracture do not have complete circulation. So if you don't take care of this initially, the bone will die. You will have the person come back 4 months later, you get an x-ray and it's all white and they can't move their wrist. So usually what I do in the emergency room is that if there's an indication that this is even a possibility just from the history or the exam and the x-ray is negative, I will treat it like a fracture. I will splint it and immobilize it, have the person, do the elevation ice compresses and so forth, and then have them come back in about 5 days and repeat the x-ray. Because then you could probably see the little whitening of the line, which shows that there's been a fracture and the bone is starting to dissolve. So then you can send them to the orthopedic doctor, and you still got some time on your hands to get this fixed. But you just can't ignore it. And if you see the x-ray and it looks negative, but the exam is telling you it's positive and you ignore it, then there's a problem with that. Okay, the fifth orthopedic emergency is a comminuted fracture of a bone. This is usually like in the femur, which is the biggest bone in your body. And if it breaks, it will comminute into 3 or 4 maybe different pieces, which I mentioned a little bit earlier in this episode. And then you have to have the orthopedic doctor take them into the operating room, open it up, realign the bones manually, and put plates and screws in there to keep them stable, because that bone will not heal without intervention and hardware placement. And the last one, number 6, orthopedic emergency, is a hip fracture and dislocation. This needs to go to the OR immediately to preserve the hip, and and especially if they need to replace the hip. And it's usually in elderly people, over 70, have mechanical fall at home or something. And the problem with this is that, pulmonary embolus is the main complication that you will have with this, which is a blood clot to the lung, which is one of my prior episodes. I think it was episode number 4. Anyway, you can look back on my file and see which one it was. Okay, now, so symptoms of a fracture. Well, obviously you have pain, you have swelling, you have a deformity. It's secondary to trauma. It's usually pretty obvious. You look at your arm, it's bent, it's angulated. Things just don't look normal. How do you diagnose the fracture? Well, that's quite simple as well. You get multiple view angle x-rays, because sometimes you may not see the fracture on a certain angle, and then you get rotated 45 degrees and get an x-ray, and boom, there's this major fracture. So you have to get different views, and the radiologist, a radiology tech, will know how to do that. Okay, initial complications with fractures. What are the complications? Well, the number 1 is pulmonary embolus, obviously. If you break off a blood clot and goes to your lung possibly from a hip fracture in an elderly patient, then that could be fatal. Other complications are vascular, where you get a compression syndrome, either from the fracture itself, that it swells so massively that it compresses the arteries and veins inside the fracture, and therefore you lose blood flow distal to that, like into the hand or whatever. It's like putting a tourniquet around your arm. And the way you tell a fracture with this type of complication, this compartment syndrome, is generally twofold. You look at the color of the skin, distal. If it turns white and pale, then that's a good sign that you're not getting any blood flow. And the way you test that generally is by what we call a capillary refill test, where you push down on a fingernail and hold it for a few seconds and then release it. The fingernail initially is blanched and white, but usually within 2 seconds in a normal circulation, that will turn back up pink. So if it turns pink in a second or 2, then you're generally not having any complications with vascular. But, if you're looking at 3 or 4 seconds and it's still blanched and white, then you got an issue that you got to deal with immediately. Other syndromes and symptoms of a compression injury is numbness and tingling in the hand. If you've ever banged your hand or sat on your leg or something that gets kind of numb. And then the last one, obviously, is if you have no motor contraction in the hand. You're losing a function of the hand, or it starts to have it like a claw hand where the hand just contracts. Those are, kind of distant symptoms of a disorder that you should have diagnosed way before that. The last one, complication of a fracture, is malalignment. If it's not set right initially, or, the surgery didn't go as expected, and, it doesn't align well, and therefore doesn't heal in a straight anatomical position of function. So, treatments, pretty obvious. There's something called RICE, R-I-C-E, that we use in any musculoskeletal injury, especially in an extremity, arms or legs, and it can be with just a sprain, contusion, or obviously with a fracture. Now the R stands for rest, the I stands for ice, the C stands for compression, and the E stands for elevation. So if you got a broken arm, you keep it elevated, you put a little ice compress on it, and you rest it and let it heal. Other parts of the treatment process of a fracture is the initial 48 to 72 hours of almost any fracture. You're just going to put a splint on, because the problem with a fracture is, it does break little vessels in the area where it was fractured. Muscles bleed, little capillaries bleed, and if you put a cast on initially on a relatively significant fracture, then it's going to continue to swell, and you're going to end up with that dreaded compartment syndrome that I mentioned earlier. So you put the splint on 48 to 72 hours, and you go back to the doctor. He re-examines it. If the swelling is stabilized and not getting any worse, then he'll put a circular cast on it, and they'll immobilize the joint above and the joint below. So you don't just put a cast around the forearm. You have to immobilize the wrist and the elbow as well, because as you know, if you move your elbow, you're moving your wrist, and you don't want that movement going on during the healing process. Now, if it's a more significant fracture, like I mentioned earlier, like a femur comminuted fracture where there's multiple fractures and some bone displacement, then the orthopedic surgeon will go into the OR and align it in an open manner, and then plate it and screw it. And sometimes they just leave that in. There's no reason to take it out, but unless you're like really young and want to get rid of it, because it drives you crazy going through the airport all the time when TSA alarm goes off. But, they can remove it usually after 6 months if you need to have it removed. So, prolonged complications or disorders of fractures. Usually it's either a delayed union, where you have a prolonged healing time, a malunion, where you have the fracture not healing in a normal alignment, a non-union fracture, where the fracture does not heal at all and it remains malaligned, joint stiffness from not using the area, and that usually requires some prolonged physical therapy. And the last one is contracture due to improper casting, that compression syndrome. So how do you prevent fractures? Well, it's not easy, especially if you got a young, active child and they're out running around all the time on monkey bars and falling off their bikes. But some things you can do is proper protection gear, helmets, obviously, elbow pads, wrist pads, and so if they fall, either roller skating or whatever, they have some protection. Other ones are, just basic common sense. If it looks dangerous, just don't do it. Know your limits. If you're skiing, don't get on the black diamond if you're intermediate or beginning skier, because you're just asking for problems, and one of those problems could be a fracture. And avoid risky adventures, even if you're a pro. A lot of pros get injuries and fractures as well, so you have to know, how to avoid these risky adventures. So there you go. There's fractures in a relative nutshell. Hope you enjoyed this. If you did, hit the like button. If you really liked it, hit the subscribe button, and we'll continue to talk about things like this so the average person, the lay person, can understand what's going on in medicine. No doctor speak here. So remember, on parting, I'm your friend, not your doctor. Any of these things come up, notify your private physician or go to the emergency room. Thank you for your time again, and I'll see you down the road for episode number 11.